Very good afternoon to all. Happy to see you again. As Sangeet said, today we are going to learn about communication part one. We have two session on communication. Today we are going to learn about the basic communication skills. Today we have an attendant faculty with us, Ms. Rajika Kurup. She has done his MSc Psychology, and also she has the PG Diploma Geriatric Counseling holder, and also she is a diploma holder in yoga therapy. Previously, she was worked with in Nirbhaya, and also she worked as a therapist for children and neurodevelopment disorders. And currently, she is working with us as a senior psychologist, and she is a very eminent faculty palliative care, because communication counseling, these all things, she is taken care of very well. She is the apt person to teach about communication today. Welcome, Rajika, and
Thank you, ma'am. A warm good afternoon to all. So my name is Rajika, as ma'am has already introduced. I know that it's noon and most of you would be like feeling sleepy, might have had your lunch and all, I hope. So we'll make this session as interactive as possible from both our ends. And I came to know that this is like a very interactive community that we having here. So I hope to see at least a few people speaking up. Okay. So today we'll be dealing with communication skills. Shall we start? At least if it's not possible to unmute and speak, at least use the chat box to let me know. Shall we start?
Yes, ma'am.
Thank you, Ashwati. Thank you, Lakshmi. Thank you. Okay. So there was a will start. So there was this study which was conducted to know, a study conducted by the headache study group of the University of Western Ontario. So they said that, like, what are the main factors which assess, like, how much, to what extent migraines or headaches can be decreased. So it was found that if we let our patients, or if we let those people are having headaches talk to us, at least have a very a deep conversation with them, it was seen that the headache kind of reduced to a great extent. So the best predictor for resolution of headache problems turned out to be, can I have the next slide, Simki? The patient's perceptions that they had an opportunity to tell their story and discuss their concerns about the headache fully with their physician during the first visit. So this came as a light, because see, most of the time what we see in a clinical setting, I don't know if it's possible at all settings to have a very long conversation with our patients, because we might be having a very busy OPDs and all. So it may not be very feasible, or it may not be practical for us to have a long conversation. But at least if we sit with the patient who is coming to us, like, just like, we'll just have a rapport building, and we'll just greet them, have make them comfortable, and just give them a space to tell about their concerns, their emotions, like what is it that really troubling them and all. It is seen that they, whatever ache or whatever physical symptoms they are like bringing onto plate, like, reduced to a great extent. So it was seen that at least the feeling that the patient's concerns were heard to, at least the feeling that the patient's story was heard by someone, kind of reduced the headache. So this is where the key importance of communication comes in. Just the mere presence of a person listening to you, mere presence of having a space where you can speak your mind out, reduces your illness to a great extent. Can I have the next slide? So, and also the fact that, next. Okay. So it is usually seen that, just a second, I'll just, yes. So it is seen that most of the medical errors that happen in our OPDs, in most of our OPDs and all, happens due to poor communication. So the medical errors that happens of the medical errors that happen, 60 to 70% of the medical errors occurs as a result of poor communication, which could be like, maybe it could have been completely prevented. We could have avoided this medical error, but due to the fact that there has been some kind of a miscommunication, or there was like poor communication, the errors would have happened. So care has to be taken while we do the communication. So if it's possible for us to do a proper communication as such, if it's just, I'm just setting up the laptop, just give me a few seconds. Okay, right. So most of the medical errors, of all the medical errors, 60 to 70% medical errors happens due to there has been some kind of miscommunication between the people. So care has to be taken that we properly communicate. From the moment a patient comes to us, we have to see that the moment a patient enters the room, then and there itself our communication starts. How to go about it, we'll be coming to those slides. So what is an effective communication? So how do we go about an effective communication? So there has to be what are the effects of having a good communication? Diagnostic accuracy. So we'll have a clear about what the diagnosis is. We'll be able to let the patient know. We'll be communicating this to the patient that your diagnosis is so and so, and the prognosis is so and so. And with effective communication, it is also possible to for the patient compliance, to let the patient adhere to the treatment plans. If at all there is no communication, if the communication is poor, if the communication or the rapport is not good between the physician and the doctor, or the nurse and the doctor, then it is possible that the patient feels, okay, I won't take this treatment at all. I don't feel like taking this treatment. Maybe I'll just skip medicines for a day or two. What wrong if I skip a medicine for a day or two? They won't feel the urgency, the importance of taking the medicines. I mean, they might just feel like, okay, it's okay. But properly, we have to communicate why this medicine is important, why it is important that they take in time, and why it is important that the patient takes up exercises, or why it is important to have a very open communication between the family members. So for having a good patient compliance also, effective communication is mandatory. And then comes patient satisfaction. So you might try this at your OPDs or anywhere at your clinics, okay? If you have a very proper communication with your patients, we see a much better patient satisfaction. Irrespective of the treatment that they get, irrespective of what their disease condition is, if they are given a space for a proper a conversation, a proper communication is made, then there is high patient satisfaction. This satisfaction comes in all domains, okay? It comes in the treatment, it comes in the way, they might be like saying outside, you might have heard this, right? Patients reporting, see, I just felt like, just talking to you itself relieves my pain. Right? You have heard that, right? See, that conversation alone is necessary to elevate pain. Sometimes the fact that, okay, I have this person to talk to itself alleviates pain. Next is team satisfaction. So if okay, right now I'm a senior psychologist with I have an interdisciplinary team over here. So we have our palliative physicians, we have our social workers, we have psychologists, we have our nurses who are in the duty, we have physiotherapists. So this forms an interdisciplinary team at Pallium. Okay, so if I'm not having a very good communication, very good rapport with the team members, and even including our patient, there will be the satisfaction as a whole team comes down. If I know some information which is very confidential, and which might the palliative physician or the nurse might need to know this information, okay? So that it kind of betters the treatment of the patient, kind of helps the treatment process of the patient. And if I'm keeping that information with myself, okay, this patient has spoken about this only to me, okay, I'll keep this information to all myself, I won't share this information. If I'm keeping the information like that, it the quality of treatment kind of comes down, okay, the quality of the team comes down. So in order to have a better team satisfaction also, it is mandatory that we have good effective communication. So I have information and I feel that this information will help the other team members for a better treatment or a better treatment plan. Then I have to convey this information to them, right? I have to share this information to them as well. So this helps in a better team satisfaction. And also it helps in patient safety. So because you know that certain condition, certain things are about to happen, and I communicate that with patient or the caregivers, and it helps in the patient safety. Okay, chances of litigation, where there is a chance that, as I said, there's a chance that they may not comply to what you are saying. They may not. There is a chance that the information is not. Somebody, right? Right. Okay. So effective communication helps in diagnostic accuracy, patient compliance to treatment plan with the doctors, what the doctor is saying, etc. Patient satisfaction, team satisfaction, patient safety, and chances of litigation. The doctor will see you now. I can't promise that he will talk to you, but he will see you. See, if a patient is coming to us and we are like giving off this information, the moment, you can see clearly the face of the man that is sitting in front of the nurse. He's like very sad and he's not very sure of, he's sad that, okay, the doctor will see the patient, but he's not ready to talk to. The patient is coming to you to speak something, like maybe his disease condition, maybe his some kind of concern, some physical symptom it could be, but give him a chance to speak the things out. So what is active listening? Can somebody say? Like, we have been listening about active listening a lot, right? We have heard this term before. There is hearing, there is active listening. So what is active listening? Can someone say? Is it something that you people are doing right now, or are you just hearing right now? Hearing is completely different. Active listening is completely different. Hearing is like, I might be sitting here, I might be listening, I might be hearing you out, but I won't be processing the information that you people are telling me. Okay. For example, I'll just read one or two names. Okay. Okay. There is this Gia who is sitting here. So Gia is speaking something to me and I'll be just hearing to it. I won't be comprehending, or I won't be go in depth. I won't perceive. I don't interrupt. I don't interpret what Gia is saying. I will just passively hearing to what she is saying. That is entirely different. What we need here is active listening. Okay, she is saying something. She is putting out all her concerns in front of me. So it is my duty to listen to it, and make expressions, make non-verbal expressions or gestures that will be in tune, in a way that assures her that I am listening to you. Okay, it could be just a nod of a head or something like that, and it could just give off the information, give off the message that I am listening to her, and I'll be listening to her, I'll be comprehending, I'll be interpreting the meaning, I'll be analyzing the information that she's saying. Maybe I'll just paraphrase. Okay, for example, I had this, the patient is saying, I had a headache yesterday and it was very intense and I was not able to sleep. So I'll be like, just paraphrase. So it would have been very difficult for you, right? Yesterday, the pain would have been very immense and intense and all, right? So I'll just paraphrase what the patient is saying. All these things is called as active listening. So we'll be like responding in some way. It could be gestures, it could be verbal responses, it could be paraphrasing, but we are actively processing the information that the patient is saying. So communication is key to successful relationship, be it a patient doctor, patient nurse relationship, be it any relationship. Okay, it could be even our personal relationship, but communication is a key for a successful relationship. Active listening is key to successful communication. So what is needed in communication is active listening, not just hearing what other people is saying, but actively processing the information. Okay. So what we are covering today. Basically, we'll be covering two aspects of communication. One is some positive body language for active listening, and the other category is some helpful verbal do's and don'ts in active listening. So, what are the body language that we need to take care of? What are the gestures, non-verbal cues that give off that we are listening to what you are saying? What are the positive body language? And the other thing is, what are the things that we are supposed to say and what are the things that we are not supposed to say? The verbal do's and don'ts in active listening. Okay, see, from this is a picture of a baby standing there. Okay, so the picture itself gives off a lot of emotions, a lot of meaning in it, right? So are we aware of how we are standing, sitting, how my hand is moving, how my face is looking? Are we aware, or are we just are not aware, and is our body language giving off a very different story about us? So, what does the child's body language give off? What are the some of the messages that the baby's body is giving off? Can one or two people say or use the chat box? Disinterested. Very good. Thank you, Ravina. Not interested. Thank you, Ashwati. Tired. I didn't do that. Okay, that was not my fault. Okay, closed body posture, bored, angry. So kind of done, exhausted. I don't want this to do anymore. Annoying. See, just with the baby's body language, okay, we were able to come up with so many facts. Agitated. Thank you so much, Gitanjali. Angry, right? So even if I'm taking the session right now, okay, I don't know if the screen is the PPT one or you can see my face. Okay, I'm just relaxing like this and taking a session. Okay, will any of you feel like listening to me? You know, I'm just relaxed. I am using the same. I'll come to the intonation, tones, and all. But if I'm just sitting relaxed and maybe drinking tea or something like that, I'll just eat some snacks in between. I might be taking my mobile phone in between. I might be reading something. So this whole body language will give off a very negative a message to you people, right? So our body language, the way we sit, the way we use our hands, the way our facial expressions are, gives off a lot of messages to the person who is sitting in front of you. Okay, so every time there is this patient who is coming over to you, make sure that the whole body language shows a interest in the person who is sitting in front of. So what are the things that we need to adapt? I'll be coming to those slides. I can't be held responsible for what my face does when you talk. Okay, I mean it's a very comical thing that is represented in the picture. Right. So this is Albert Mehrabian's model. According to this model, the spoken words that we use only takes up 7% of the total communication. Okay. So the verbal communication that we use, the words that we use only takes up 7% of the complete communication that we are doing. So the remaining 97% is the non-verbal thing or the body language. And apart from the 93%, 38% takes the voice and tone. If I'm talking in a very monotonous, completely, I might be speaking in the same rhythm, same same rhythm and same uh, tone throughout the session for 1.5 hours. It would be very difficult for you people to listen to me, right? It won't it might cause a lot of disinterest in amongst you people. So my voice, my tone, the intonation that I use, the highs and lows of my voice, everything caters to the way we communicate. And 55% of the whole thing of the communication part is being judged by the body language, is being done by the body language. So out of the communication, if 100% of the communication, only 7% takes up the verbal words or the spoken words. And apart from this 7%, the 93% is being taken up by the body language and voice. So body language and voice has a greater role in communication when compared to the verbal words. Is this clear? Are we on the same page? Thank you. I can see a few nods, which is very helpful. Thank you, Rosamma, Joseph. Thank you. So what are the some of the positive body language? So we'll be coming to each one of in details. The first one is eye contact. The second one is facial expressions. Thank you, Sunaina. The third one is tone of voice. The fourth one is body position. The fifth one is body posture. Sixth one is body space. And seventh one is touch. So we'll be looking into each of these factors. Okay. So first one is eye contact. So the moment you need to create a relationship with any person, okay, be it any stranger, be it your friend, be it your family member, be it your patient, be it anybody, the first thing that is going to mark the benchmark of the relation is going to be the first eye contact that you are having. So I'm sitting over in this room. So there is this door over there, just imagine, and a patient walks in. Okay, the first thing that I have to establish is the eye contact. Okay, I cannot just, I have the patient, okay, the patient might be let in by the nurse. Okay, I might be reading the patient file and I'll just note, okay, come inside, and I'll be like looking at the file. That moment itself, that moment itself kind of, disengages the relationship. There is like difficulty in forming a proper relationship with the patient. So the first and foremost thing that you have to create is the eye contact. So the patient is over here. Immediately, even if I'm having the file in my, yes, Yankila, I think you have doubt, or is it? Okay, I think it's by mistake, right? Okay. So the patient is coming over. I'm looking up the file and reading the case sheets. What is happening? What are the physical disturbances that the patient is having? So I'm looking at the case sheet and reading, and I'm not catering to what the person is, who the person is. I'm not giving any eye contact. The patient is coming over here and sitting beside me. Okay, there's a chair beside me, and the patient is sitting. Even then, I'm not looking at the patient. I'm okay. So what are the concerns? I'll be reading the concerns from the file. I'll be like reading the demographic details, everything. So what are the concerns? So she will be saying, but just know that the communication part, the respect that you're going to get is might be like 50% less than what you get when you meet the person with the eye contact and slightly nod. You may not know the name of the person, but make sure that you at least give a nod in that direction. Okay, so the patient is coming over, the patient is at the door. I'll just, even if I'm having a looking, I'm looking at the case, I'll just raise my head and give the eye contact. I'll just nod and let the patient be come here near me and be comfortable. Okay, this is the first thing that you need to have. So, what are some of the tips for making eye contact? When you look, do it slowly. It's not an abrupt look that you're going to give. Okay, it's not like you are going to threaten them. Okay, so I cannot just stare at them. I cannot just abruptly look them. I cannot just, it's not a very fast movement that you need to have. It should be a very slow paced, very gentle movement that you need to take up. So the eye contact should be very gentle. Don't look down when you look away. So there is a chance that we may not be able to always look in the eyes of the person, right? We cannot just stare at them for long hours. Our eyes might get tired, we might be distracted, we might have to look away. So don't just look down when you want to look away. So there is something called as good triangle. I'll be coming into that in the next slide, I think. So rather than looking away, look at any other spot on their face. Okay, so it's human tendency. Okay, it's natural for us to get tired, or you might be distracted, you might want to look away, but without disrespecting the person who is sitting in front of us. So without disrespecting, if you don't want that person to be disrespected, the thing is, look somewhere elsewhere in the face. Okay, so you are taking your vision of the eyes and looking some at the points in the face, and that is called as a good triangle spot. I'll be coming to that. So break your gaze to make a gesture or a nod. So if you want to break the gaze, just make a nod, and just gentle slight movement is what is necessary. So make eye contact before you start talking to someone. So always keep this in mind. Any people that any person you are having a conversation with, it could be anybody. Okay, this could actually be used in your personal as well as professional life. Okay, so make sure that you have an eye contact before you start speaking. So this is a good triangle, okay? So you want to move your gaze away from the eyes. So you can put your gaze at any of these 3 points, okay? You could look at their lips if you want, somewhere around the right cheek or somewhere around the left cheek, okay? So you want to take gaze off the eyes and look somewhere else on the face. So this is the good triangle. So if you look at any other spot in this good triangle, it is fine. It's not disrespect. It's completely fine to have a to look at any other spot other than the eyes. Okay, so the patient came up and is sitting beside you. Make sure that you smile at them. Okay, so obviously we know for a fact that being in a palliative setting or being in a hospital, they they may not be coming to you with a good news, right? It might be something that might have shaken them, that might be concerned of. They might be sad. They might already have visited some other doctor. So it is possible that they are not they are to some extent they may not be able to smile at you, but if at all it is possible and if you know the case and all, make sure that you smile. And even if you're wearing a mask, you know that for a fact that you can see your smile in your eyes, right? You can see your smile in your eyes and it can be heard in your voice. So there is something called as professional smile. Even if you're wearing a mask or you're bereft of a mask, make sure that you smile. And even if you're wearing mask, it can be seen in your eyes, right? You can try that, right? For example, I think the only person who is sitting in this whole crowd is Gia, okay, with the mask. I'm sorry, Gia, I'm picking at you again and again, okay? So she is wearing a mask, right? So even if she smiles, we will evidently know that she's smiling because the eye speaks, right? The smile can be seen in the eyes. And if you are not wearing a mask, then it's well and good. The smile can be seen. So smile, eye contact, and then smile. Keep these 2 points in your mind. And also, if you're wearing a mask, make sure that the smile is heard. At least some voice is there to your smile. Okay. And next comes the tone of your voice. So how you say, how you talk matters a lot. But okay, just try, and all of you just try. It's okay if you are in mute. Okay, the way we talk while we are smiling is completely different when we are having a very grumpy face, right? So I'm having a grumpy face and sitting, and I'm talking. Then obviously my the tone of conversation will be different, right? But at the same time, okay, I had an eye contact, I had a smile. The moment we have the smile on your face, our tone naturally changes. It changes to a very pleasant, very in tune, very. It's not going to be very angry or something like that, right? So the smile itself takes care of the tone. So the important factor is you smile. Okay, if I'm not smiling, I'm having a very bad day, I'm having a very grumpy face, so my tone is going to be grumpy, the whole conversation is going to be grumpy and very bad, right? So make sure you smile in the first place. Am I clear till now? We talked about eye contact, we talked about smile, and the good triangle, and then we talked about the tone of voice. Okay, thank you, Mari, thank you, Aruna. So now we are coming to body positioning. Okay, so this could happen in IP section, IP wards, or OP, wherever you are having your patients. Okay, so the body positioning when compared to the person who is sitting in front of you, mostly our community or our population is going to be our patients. So it's so let's just look at the 3 pictures, okay? At least just the first 2 pictures, okay? The left one and the right pictures. So what differences do you feel? Okay, look at the first picture. Is it a very good poster that they are having? The first picture, okay, where the doctor is standing beside the patient and talking. Do you think the patient is comfortable or is there any discomfort? Thank you, Pratima. So what is it? Why is it not a very good posture?
Is
Sorry.
it because the doctor is standing at the left side?
Usually it has been taught that we have to stand at the right side.
It's one of the reasons, but from the patient side, thank you so much, Twinkle. So what is the discomfort that the patient is having? Yes, thank you,
Maybe
Rosama. More authority to
towards the left.
doctor. Yes, Twinkle.
Maybe he has difficulty to turn towards the left side to talk to a doctor instead of stand. That would be better for him to turn on the other side.
Okay, thank you. She should be in the front. Very good, Kumari and Rosama. Thank you. See, standing there and the patient is lying over there, it gives of some authority to the authoritative figure to the patient. That I'm someone above the patient. Okay, he's lifting his head to talk. Very good, Ravina. He is bending over. He's straining his whole posture in the backside. The neck area, the back spine, everything is being stressed over here. So he is bending over to talk. So the best thing, if at all you are standing, is to stand at the foot end of the patient bed. Understand? You have to stand at the foot end of the patient where the patient will be in a very relaxed posture. The patient does not have to bend over, does not have to lean over or bend his head or lean or, cause any discomfort for the patient. So it is always suggested, if at all you are talking to a patient, by standing, it is mandatory that you stand at the foot end of the patient, foot end of the bed, right? So the patient can have a very clear vision. Okay, he doesn't have to stress upon any part of the body. But the best thing is to sit by the side, right? Yes, stand in front of the patients, right? So, but it is always best, if at all it is possible. See, it's not necessary, it is not mandatory that it is possible for all the IP wards or the patient where the patient is lying to. It's not possible to have chairs. If at all it is not possible, you will be standing. But if it is possible to sit beside the patient, it is the best posture that you could adopt, because the body leveling is equal. You are equal with the patients, you are at equal length, you are at what do you say, the eye level of the patient, and you are talking in terms of the patient satisfaction is much more when you sit beside the patient and is talking. So the patient is relaxed, the patient is very comfortable in the second picture, the patient, the vision, everything is okay, and there is no authority figure or anything. Everything is kind of at body level, the body level is equal, and the patient satisfaction is much higher. And when you are talking to children, especially, what we tend to how we tend to talk is that we kind of bend over our hip area, right? We bend over and we'll be speaking to the children, right? That's what we usually do, right? But it's always best to bend at our knee level, or exactly you can use a similar thing, right? Like we use in the adult patients, you can pull a chair and sit at the level with the children. Okay, either it could be sitting at the level of the children, or it could be bending at the knee level. I know it is not very possible, and it is very rarely we see those kind of things in our hospital settings, right? Most probably what our doctors will be doing, and our nurses or doctors or any physicians will be doing, is that bend at our knee hip level, and we'll come to the level of the children, we bend to the level of the children and we'll be speaking. But instead of doing that, it could be best if we like bend at our knee level, or pull a chair and sit and have a very so that the body level is equal. Any doubt in this area? All right. So moving on, body posture. The body posture that we give off, thank you, Kumari, give you off is very important. So a patient is coming, as I mentioned earlier, or I don't know how many of you have home care and all. So I'm visiting a patient at home, at his or her home, and I'll be just taking a phone and going and talking to the phone, and I won't be giving importance to the caregiver or the patient, or I'll just act busy, okay, or I'll be busy, not giving time for the patient who is near me, or the patient at home, or wherever it may be. It could be any other personal relationship also, okay. This gives a very negative idea. Also the body posture, that I'm very relaxed, that I like, as I previously shown you, if I take into a very relaxed posture, I'll be just leisurely sitting, it will give off a very negative idea. to the patient who is coming to you. Already the patient is in a very vulnerable position, or else obviously they won't be coming up to a doctor or a nurse, right? So they are already in a vulnerable situation. So it is our duty that we keep the body language speaks of interest, of the passion that we have. Okay, so whenever we are talking to a patient, make sure that we bend forward. Just a slight bending from our part shows that you are interested, you are listening, and the patient satisfaction is much more when you adopt this body posture. So the patient is here, I'll slightly bend over, which gives off the message that I am interested in what you have to say. In whatever you are going to say, I am interested, I am listening to what you are saying. Okay. So the bend forward body posture is showing that you are willing to listen. Here, the patient satisfaction is much more than when you are when you adopt a very leisurely, relaxed body posture. Okay. So always bend forward. And there is something called as bend forward or leaning forward. There is something called as mirroring. Okay. So if the patient is leaning forward, you can lean forward. And if the patient is like moving a little back, then you can just take a back seat. You can just come a little backside. This is called as mirroring of the person who is in front of you. If they are leaning forward, you can lean a bit forward. And if they are like leaning backwards a little, you can take up that position. So mirroring what this person is in front of you showing, like, makes you more likable. It's more psychological. It makes you more likable. The patient feels like, okay, you in some way you are listening to you're giving that space, you are showing interest, you are showing concern, you are having attention, you are listening to. So it gives off a lot of non-verbal messages to the patient or the person who is sitting in front of you. So try to mirror, but mostly, if at all the patient is not showing any other body movements, lean forward, okay? Bend forward. Bending forward gives off the idea that you are listening to them, right? Okay. Then there is something called as respecting the body space, okay? For example, the patient, whoever is coming to us, obviously we know that they are going to have, they are vulnerable. They might have some physical discomfort, which we might need to assess, for which we might have to intrude their personal space, right? So what we do, we'll just take this step and we'll be putting this step. If it's the catheter, we'll just remove the catheter, put the catheter. If it's a Riles tube, we'll be like doing that. We'll be just taking that we'll be like going to into their personal space. We won't be taking any consent. We are like disrespecting all the rights that the person is having, right? So before you do anything, even it could be just putting a step on their chest or to listen to the heartbeat. It could be even as simple as that, but make sure that you take the consent of the person. At least let them know. See, I'm going to keep that step. Okay, is it okay? Is it okay? Are you okay with that? Just take a slight consent. We know that already. Obviously, we know for a fact that the people who are coming to us, for example, doctors, nurses, and all, implied consent is there. Obviously, they have some discomfort. Obviously, they know that step will be put, some kind of investigation assessments will be done. They might catch our wrist, they might catch here, they might catch your shoulder. See, implied consent is there. They know for a sure a fact that you will be doing this, but still, just inform them prior to doing that. It gives off a lot of confidence, a lot of respect to themselves and to you as a physician, right? It could be as a physician, right? So always respect their boundaries, respect, take consent, at least let them know that you're going to do this. And this is with the patient that can speak, okay? And if a patient is bedridden, he's in Riles tube, we cannot verbalize his needs, make sure that even then, make sure that you ask for it, right? You have to remove the catheter, and the patient who is a 56-year-old, he's completely bedbound, he is not able to verbalize his needs, he cannot speak anything. Make sure that, okay, we usually call acha amma, okay, for elderly patients. We what our nurses, what our sisters do in here is that we are going to remove the catheter, okay? We'll just let them know. We don't know whether they are comprehending the fact or not, we don't know whether he is listening to the fact or not, but we'll just let the patient know, right? We are going to do this. See, what if they can know, right? See, we have to respect the patient as an individual, right? So before removing the catheter, just let them know that, okay, we are doing this. And before maybe inserting a catheter also, okay, I am going to insert this catheter. Even it could be catheter, it could be Ryle's tube. And if it's a very normal OPD that is happening and it could be fever or we might need to check the heartbeat or something like that, just let them know that we are going to put the stent, right? Okay, when it comes to body, we have like different spaces. There is this intimate space that is where only we and a very personal, very personal people very close to us have access to ourselves, and maybe it could be our parents or it could be our spouse, anybody, right? That is called as an intimate space. Then we have the personal space. It goes beyond our spouses or ourselves to where our close friends are there, our close family relatives are there. Okay, then comes the social space where we have our colleagues, other social people, other colleagues and other people are there. And then we have a public space where we have strangers. For example, you are standing in a bus stand, okay, there are other peoples around you, right? So that is the public space. And when you are a social space is where maybe a setting where you are in working in, maybe a working place could be so called as a social space. A personal space is maybe your home. An intimate space is like very personal, very intimate. Maybe it's just you and your spouse, or it could be a parents. It's very personal, very intimate space. So before invading their space, it could be social, it could be personal, it could be intimate. Before invading their space, even though there is implied consent is there, discomfort is experienced from them. Okay, even if we are talking to them, there could be a chance that we are invading their boundaries. So inform prior to them. Right. So in the first picture, we can clearly say that the patient the patient is like very threatened. Like from his face, threat can be seen, right? He feels threatened. He feels that the boundaries were crossed, right? He feels agitated to an extent. He feels that his personal space has been crossed. But what's the major difference? What could you see in the second picture? How is the patient, how is the patient and the physician who is sitting beside? Any messages, any relaxed? Very good. The patient as well as the physician both are very relaxed. The body leveling is equal, right? They are at the same level. He is relaxed, she is smiling, she has eye contact, if you can see, right? The patient is very comfortable, is talking, is having a conversation. He feels like home. He does not feel any discomfort. Yes, eye contact, thank you. Both are comfortable. Both are having a very comfortable conversation. See, there is respect, there is smile, the body leveling is accurate, everything is there. But in the first picture, we can clearly see that the the physician is invading the space. The patient feels discomfort, the patient feels threatened, the patient feels the boundary has been crossed, there is disrespect. The facial expression of the physician also give off a very authoritatively kind of messages. He's a bit aggressive maybe, right? So these factors give off a lot of information. So it is important to take care of the body posture, the eye contact, the smile that you have, the respect that you give through the conversation, etc. Right. Next, the seventh point that comes in here is touch. I don't know how many of you are aware, touch is very, very therapeutic. Okay, no matter, I know that we had a crisis during COVID where we were even afraid to talk to people, and touch has reduced a lot. But make sure that whoever is sitting in front of you, a simple pat on the hand will do great magic. It's beyond words. Okay. I have seen cases where, obviously I'm working in a palliative setting, so I might have to see a lot of bending out. Obviously the counseling sessions require a lot of bending out, a lot of breaking bad news, a lot of pollution things and all. So we might have to break things down. So I have seen patients, I have seen caregivers who are at the brim of, venting out, brim of crying, but they won't do that. they might be keeping all the emotions to themselves. But if that right moment, if I just pat on their shoulder, if I just hold their hands a bit, firmly, they'll just start crying like anything. They just need that one touch. Obviously, it's not in a way that is causing discomfort to them, not in a way that see, we cannot just directly go and touch. You need to have a good rapport with the person who is you are going to touch, right? It's make sure that it's not a complete stranger. Obviously, you need to build the rapport during the conversation and the communication part. And the simple act of touch can take the communication to a very great level. Okay, it's very therapeutic for the patient as well as the physician. Okay, we can see the amount of relief that comes to their face. They feel they're at par with you. They feel like, okay, we are like very they can easily bond to, they can easily say something. They feel like, okay, this is one person, may I feel like home. That kind of feeling comes when you use the form of touch in your communication part. Okay, so see, we might feel a little hesitant, right? Obviously, it is understandable. A lot of diseases are there, right? Communicable diseases are there. A lot of issues with hygiene and diseases and factors. Everything is there, but it is fine. You can use the sanitizer immediately after the touch, even in front of the caregivers as well as the patient. It is completely fine. See, you are a physician who is like working with a lot of patients, right? You have an n number of patients. You might have you it is possible that you also communicate this disease when you're like looking at another patient, right? So it is completely okay if you want to sanitize, use hand wash or anything after the session. It is completely fine, but make sure that you there is some kind of physical assurance is there in the communication part, right? So anything in the first area of our communication, that is the positive body language. We touched upon eye contact, how eye contact is going to help, the facial expression, smile, the tone of your voice, how you have to like positioning of your body, using of hands, everything, the body posture, body space, how to respect that, where you need to stand when you're talking to a patient or to a child or that kind of thing, and how to use touch and how touch is very therapeutic. Any doubt in this first section of communication? If at all there is any doubts, please use the chat box. Any queries, anything, just let me know. Even if we are like going beyond this, you can just put the question in the chat box. Okay. Thank you so much for the people who are interacting, using the chat box, unmuting yourself and saying, it takes a lot. Thank you so much.
Thank you, ma'am.
Thank you. So we are coming to the second part, that is some verbal do's and don'ts. So what we have to say, what we need to say, and what we shouldn't be saying. Okay, we'll be coming to that section. So don't ask leading questions. So there are like different types of questions. Okay, there are close-ended or leading question. Close-ended questions means whether you had breakfast or not. It's a very close question. Either it can have yes or no answer, right? You had breakfast or no. It's like the two answer question, right? So there are close-ended questions are there. There are leading questions. For example, we might be leading the patient to the answer. For example, I'm asking, your breathless is better now, right? See, we are assuming that the breathlessness is better, right? We don't know. And what the patient, if I am the patient and someone is asking me, see, your breathlessness is better, right? So I feel like, okay, I took this medicine, so she expects my breathlessness to be better. So I might have to say like the breathlessness has got better. Maybe I have to say a yes to this, right? These are types of leading questions. The answer is already there in the question. Your breathlessness is better. The answer is already there in the question. So we should completely avoid leading questions. You did sleep better last day, right? Last night you did sleep better, right? So even if I had a very disturbed sleep, I might be in a position to say that I had a very good sleep, because the physician or the nurse or the caregiver expects me to have a better sleep. So these are leading questions. That is, the answer is already there in the questions. We should completely avoid this and we should ask open-ended question, which gives them space to actually open up of the actual facts. For example, you can use any WH questions. For example, what, when, where, how are you feeling today? Why is that you're feeling not down today or feeling discomfort? Why is that? From when did you feel this? These using WH questions gives a lot of exposure, gives the patient to explore more into what the patient's condition is. For example, how are you today? It's simple as that. You can just ask if Shiba ma'am is coming to me and asking me, how are you today? See, I might actually say all the information that I feel like. See, I'm not feeling well today. I don't know why. I don't know the reason of feeling. I completely feel agitated. I don't know the reason. Instead of that, if Shiba ma'am is coming and asking me, okay, you're feeling great today, right? I will like, okay, yeah, I'm kind of feeling great. Yeah, thank you. The conversation is cut short there, right? But instead of that, if you're asking an open-ended question of how are you, I might start, expressing more, explaining more, and there is a scope of assessing. We can actually assess what the real condition is. So always ask open-ended questions. Next, don't minimize or don't compare patients' problems. See, it's natural tendency of humans, right? We have seen that, even as parents, we do compare our children, right? There's a tendency for comparing, right? Okay, if okay, the 12th exams, the results are out, the ICC results are out. See, I'll be comparing a child with someone else, right? Okay, so and so had so good marks, so why are you not having? So it's very natural tendency for humans to compare with others, but never compare, never minimize others problems, okay, especially when it comes to patients. Don't get so worried over such small problem. Okay, for example, if a patient is coming to you with just a slight toothache, okay, the patient is having toothache, and for that patient the toothache is the biggest trouble that the patient is having, right? You might be a palliative physician, you might have seen cancer patients, you might have seen patients in end of life, you might have seen patients with severe pain taking morphine, etc. But when this patient comes to you with the toothache, you shouldn't compare. See, I have been working in palliative care since so and so, and I've seen so much pain. When compared to that pain, your pain doesn't seem much. It doesn't seem of great importance. It could be like easily treated with a paracetamol. You can just take a 1 or 2 painkillers and you'll be relieved of this pain. Never ever minimize patient's problem. It could be a toothache, it could be a headache, it could be a slight injury, but for that person, it is of utmost importance, right? Never compare. See, we might start talking. See, I have this patient back in 2020. She came with severe pain. She was having osteosarcoma and she had very severe pain. She was in stage 4, no morphine, no tramadol, nothing was helpful, and she had so much pain. And you're coming and talking to me about so and so things. These are so silly things. But never do that. For them, whatever concern they are bringing onto your plate is of high importance for them. Okay, there are so many people who are facing much. You should never use these things. Okay, never compare with your own experiences or the experience that you had in your clinical services. They feel you don't care. So any patient who is coming to you with any slight pain, be patient, ask why and what, how is it concerning him, and be there for him. Don't minimize the pain. So what we need to do, acknowledge and normalize patient's emotional experience. So emotional experience towards pain is very subjective, right? My pain is not going to be similar to Shiba ma'am's pain, or it is not going to be similar to Rosama ma'am's pain, right? It is, everybody's pain is different. The tolerance level is different. So we should never compare. So acknowledge and normalize patients' emotional experiences. The pain tolerance is different. Anybody in your position would perhaps feel this. Acknowledge their pain. See, maybe the pain that you're going through is like way beyond my imagination. I cannot even imagine myself. It takes a lot to go through this. We are acknowledging, we are saying how strong that person is to go through this, right? Anybody in your position would feel this way. considering what you are going through, it is normal, it is normal to feel like you don't feel like, there are patients who come to you and say, I don't feel like living, I just feel like giving up my life. I just feel like committing suicide, it's acknowledge that, see what you're going through. It is for a fact that you feel these things, so what is that you're concerned? What how can I be of help? What can I do in here? These are the things that we need to assess. These are the way we in which we need to take the communication forward. Never compare, never say it's a very small thing. Acknowledge whoever is coming in front of you, the pain, the emotional experience that the person is having. Don't give false hope. Never ever say that, this is going to be completely okay. See, everything will be all right in the end. See, we have facilities that will take care of all your problems. Never ever give false hope. Whatever is the actual information, okay? See, we'll be coming to the Breaking Bad news, how to give off the information in the next session. I think that is happening on Friday. But I'll just give a rough idea. We never give false hope. We never say that everything is going to be all right. What we will, you should say whatever you're saying should be of facts, written in the assessment forms, but in a way that will, after making them comfortable. It's a very huge process that we'll be coming to. So do give realistic hopes. Your disease may be progressive, but I'll do my best. I'll do whatever within my capacity to relieve the symptoms. Symptom management will be done, or to make you comfortable. Whatever is within my capacity to make you comfortable, I'll be doing that, or my team will be doing that. Never say that, oh no, all your pain will be gone. We'll be take care of all your issues. We have so and so facilities. Never, and you'll be completely fine. Maybe this person is in EOL stage, okay, and you're saying that the patient is going to be all right. The information that the caregivers and the patients will be receiving is completely different. So never ever give false information. Whatever information you are giving should be of facts, should be correct, and should be honest, but in a way that after making them comfortable, okay? And how to make them comfortable, everything we'll be like discussing in the next session. But give realistic hope. We'll do, see, your condition is progressive, okay? We can see from the reports that the condition is a little progressive, and we can we'll do to whatever from within our capacity to make you more comfortable, to relieve the symptoms. What can be done for the symptom management, or the other things that can be taken care of. Do not assume. How is your breathlessness? Much better. Never assume what the patient is going through, right? Never assume that it is better, so I may not need to ask this question. Ask. Don't assume what the patient is going through. It could be completely different from what your assumptions are. So ask, come out, ask, and get the answers from the patients. Do you have satisfactory relief? Not really. So don't assume of their satisfaction level. Don't assume that they are not satisfied. They might be satisfied. They may not be satisfied. Ask whenever is possible. Have a proper communication. Right? Any doubt in the second category where we discuss some of the verbal do's and don'ts? Never ask leading questions. Always ask WH questions or open questions. Never put your answers out there. Never compare, never minimize the pain that they are going through, or the patient, or any person who is coming to you. It could be a friend, okay? It could be a friend who is coming to you and saying something, and you cannot say that, oh, I faced this problem back in 2019, and I did this, I managed with so much strength, this is easy for you. You will also come over this. Never say that. It could be any relationship, okay? Never do that. Never compare, never minimize. Acknowledge, do whatever is possible within your limitations. Never give false hope. Never say that everything is going to be all right. You'll be fine. All is well. Never say. Whatever you're saying should be of facts, honest things, and do what we'll be doing from what within our capacity to relieve your symptoms or make you comfortable. Never assume. Right? So we'll be moving to history taking. That is the last cat. Yes, someone?
Sorry to disturb, ma'am.
No issues, please.
Just can you give me? I understood with the examples, but can you give me a difference between the leading question and assuming?
Right. assuming is actually not putting in words. It could be in our head itself. We are assuming for a fact that the patient is having some issue. Like we won't be actually putting in words. It's not necessary to put that in words. It will be there in my mind that Shiba ma'am is all right. I'm assuming that she is all right. She is sitting, she is smiling, so I'm assuming that she's fine. But deep down within her, she may not be fine. But because she is having a very smiling face, she always has a smiling face for a fact. Okay, because she is having a smiling face, I'll assume that she's fine. Right? I won't be even questioning her because anyway, she's smiling around, right? Okay, she's having a very good life. I'll just assume that she won't be having any pain. There are patients who won't actually show the emotions of their face. They'll like try to put a very, especially if you're like if you had very palliative patients who had like work with army and all. I don't know if you had, like, we had a few army people here, okay? And he has been working with army like for 50 or 56 years and retired, and now a palliative is, he's very like, they won't really give off any emotions. It's very below their what do you say, emotion, that to show weakness. People won't be in a position to show their weak part, right? So we'll assume that okay, he's fine. But if we have a conversation, it is very difficult to have conversations with people who actually take deliberate effort in showing that they are fine. It take another 4-5 psychological sessions, counseling sessions. After building rapport, like the person will completely break down. So never assume with whatever they are showing. Sit with them, have a conversation. We'll know that it's not what we assume that they're going through. It happens in our personal relationship also, right? We assume that a friend of ours is fine because she's smiling around, and we'll come to know that she committed suicide. I don't know how many of you have experienced that. At least you might have heard of stories like that. He was in the party yesterday. He had a very gala time, and he went back home and committed suicide. There are people who, especially with depression and all, we have like there is a lot of assumptions that everybody they have to like show that they are depressed. No, never assume what a patient or a person is going through. It's beyond our thinking. We never know unless we sit down with a person and have a conversation with that person. Leading question is, we are like putting the answers within inside the question itself. You are feeling much better, right? The right thing will be there. You're feeling better, right? You slept well, right? That kind of thing. Thank you, Twinkle. Right.
Thank you, ma'am. Well explained.
We'll be moving to history taking. So this happens when a new assessment is going to be taken. Okay, so there is this new patient who is coming over the OPD, and you are going to take the history down. And mostly this is done by our nurses, right? I mean, everybody does this, but maybe the first hand would be done by the nurses. So patient is there. So what we'll be doing here? We'll first make our eye contact. The patient is at the door side. We'll make eye contact. We'll smile, nod, and greet them. It could be in any language, your native language. It could be namaste, namaskaram, good morning. It could be anything. So the eye contact is made, a smile, no, namaste is given. And we'll make sure that the patient is very comfortable. We'll offer a seat in the OPD. We'll ask them to sit down, or we'll be like, sit, if at all it's a IP ward rounds, we'll be like sitting beside the IP patient. So the leveling, body posture, everything is right. So we'll start the interview with an open-ended question. For example, how may I help you? Obviously, they came in for some help, right? They won't come to a hospital or a doctor or a nurse without being in a vulnerable situation. They came to you because they need help. So what brings you here today? Like, how can I help you? How are you today? So these are some of the questions that we can ask. If the patient is already there in the IP, you can start off with, how are you today? How are you feeling today? Okay. Listen, do not interrupt. There are patients, they'll start telling their stories. Listen to them, never interrupt. But there are cases where the patient will go about saying a lot of things. So I went to this marriage, and then this happened, and I came back, and then there was this rain that happened, and I caught a cold. There at times we'll get a lot of stories. A lot of derailing can happen, but make sure that you bring them to the track again. Okay, back on track again. Encourage patient to talk. Maintain eye contact. If at all you want to remove your gaze, just look somewhere else in the face, or do a slight nod. The eye movement should be very gentle. Nod your head from time to time, so that to show that you're listening. Encourage sounds with right. Go on. like use words like that, clarify as you go on. So you didn't get something that they said, or you need one more time clarification, ask, I do not understand this part, can you please repeat what you said? Ask about what they understand about the situation. So if it's all a disease condition, so can you say something about your disease conditions? What do you make out of this result? What do you think you have? What did the doctor there tell you? Do you know what the report says? Just getting an idea of what the patient already knows about his current situation. Ask about their concerns. What are your major concerns of is it pain? Is it like how much you're going to suffer? There are there might be a lot of questions that the patient is having. So just ask, what are your major concerns? What is it that bothering you? Is there any concerns that you have? Any other questions that you need to ask me? Share information honestly. Whatever information you are going, it's going to be in a very simple language. No medical jargons, medical terms that you are using. Whatever you're saying, it should be facts. It could be honest. And at that time, there might be a lot of emotional outbursts that are going to happen. The patient might cry. The patient might scream. The caregiver might cry. The caregiver might scream. So there are a lot of emotions that are going to happen. They might actually be angry towards you. You have to remain calm. It's because of certain issues that they are behaving, so the responses are be so and so. So use simple language, but whatever you're saying should be very honest, factual things that you're saying. Discuss treatment options. Do not give a menu of options to choose from. Discuss pros and cons. These are the alternatives that you have. You have so and so. Recommend a line of treatment. You are more than a prescription vending machine. Okay, it's not just you're writing down on something and just giving it off. Listen to their beliefs, fears, problems, constraints. Even if we give them best suggestion, it is not necessary that they stick to that suggestions, right? What if they want to take up any other alternative treatments? What if they want to continue with Ayurveda, or they want homeo to be taken care of? There is chance that it is not always necessary. Whatever plan or treatment plan that you are giving, it's not necessary that they have to completely stick to that, right? There is a chance that they might be completely having a different belief. Whatever it is, we have to let the patient decide for what they want to take up. Participatory decisions by concerns. For example, the patient will be there, family, doctor, the caregivers will be there. We'll be like having a participatory decision. We'll be sitting together. What is good for this patient? What is not? What might work for this patient? What may not work for this patient? We'll sit and decide the treatment plan. Summarize the interview. Confirm the treatment plan. So according to what we have discussed, we have come to this conclusion. So we'll be starting the chemo the next week, or the radiotherapy as per the patient's decision or wish, and so will be done. Before you close the interview, ask, is there anything else you want to ask? So because we have seen in most of the cases, there might be some doubts, some queries that the patient or the caregivers are having, but most of the time they won't ask these questions because they feel like the nurses, the doctors are of higher authority, and they feel like, okay, I don't think if I ask this, it may not be right to ask this question. It may not. They might feel bad. They won't ask the question. So it is better from yours end to start the question. Is there anything else you want to ask? Is there any doubt or any clarification from my part, or anything else that you want to know? There are at times, people will start saying, at times we had like one patient who, when one of our doctors asked this question, they were having a very personal session, and he asked, is there anything else you want to ask? And she asked, I think she replied, how long will I live? This came up, how long will I live? How long is this going to take to cure? So it is important to ask this question before you terminate the session. Close the interview, leaving the door open. In case you need to contact me or my team, you can give your official number, official timings, everything, so that they will call you up when needed. Greeting, make eye contact, smile, note, bye, good day, namaste, apusheri. Apusheri we use in Malayalam, okay? Apusheri kana, bye. Right? So that's how we end the assessment. So that's regarding the history taking. So I'll just come to a few take-home messages. Empathy as an experience depend on how we behave with our patients and their family. Patients and family remember how they made they were made to feel how they felt during the conversation, right? They always remember this. They always remember who talked to them politely, how a doctor made them feel or a nurse made them feel. They are always going to remember it. Even if they're like, even if it's been years, they will say that, there was this nurse who worked in this hospital, had a very great conversation. She was like a daughter to me. She was so good. We have patients who say, acknowledge the people, the caregivers, the healthcare workers. That's what they mostly remember. Talk less, listen more, practice body language. See, it's not one thing that you can just immediately take. You cannot have a professional smile from tomorrow. It takes practice. It's a skill that you learn. You need to inculcate. You need to practice these things. Only through practice, this is going to be a very natural thing for you. Practice positive body language and remember the verbal do's and don'ts. The most basic of all human need is the need to understand and be understood. And the best way to understand people is to listen to them. With that, I wind up my session. If at all there is any doubts, queries, and all, please.
Thank you, Rajika, for the wonderful
No,
presentation.
ma'am. Thank you.
Anybody have any questions or comments?
Madam, you have mentioned that we should not be discussing the treatment options, but actually we should be telling all the options available to the patient.
Exactly. I
Can you
think so.
clarify?
Sure. We need to do a discussion. It is clearly said in the presentation also, we need to have a proper participatory discussion, but the decision should be made by the patient. We need to have a proper discussion. We need to say all the things that are to be done, how it is going to be, the prognosis, the diagnosis, everything has to be put on the plate. But the decision whether the treatment has to be taken or not, whether he wants allopathic treatment or whether he wants Ayurvedic treatment or whatever treatment. There are patients who say that, I don't need any treatment at all. It is okay if I am left at home itself. I won't take any treatment at all. If at all a patient is saying that, we cannot force medication into that person. Okay. So the decision has to come from the patient, but obviously the discussion part has to be a very participatory. The caregivers has to be called in, the doctors or the spouses, the partners has to be called in, the patient has to be, even this has to be conveyed to the patient also. So these are the methods, these are the treatment things that we are having for you. You will have like 10 cycles of chemo or 12 cycles of radiation. So this is how to go about it. Maybe you might have to need to take a surgery. So these are the things, these are the outcomes of the things. There is a chance that if at all the patient is in stage 4 and we are suggesting for a chemo, if there is a chance that the chemo may not work, right? We might have to actually say that also. There is very less chance. If at all you take this chemo also, there is very less chance. How we need to say this, the prognosis and all, we will like discussing in the next chapter. But we need to say the facts to the patient as well as the caregivers. We need to discuss, but the decision will come from the patient. Thank you.
Thank you.
Thank you.
Ma'am, I have one doubt. In case the patient having psychotic problem, the patient cannot take the own decision, no? The family members only to take the decision, correct?
Exactly. Thank you so
Yes.
much, Rajeshwari. Right? If at all a
Yeah.
patient the patient is having delirium, the patient is having dementia, there is some kind of cognitive impairment, the patient is psychiatric, then obviously we need to listen to the caregivers. The decision had to be made with the caregivers. So what we do in our pallium is that we make the decision from the caregivers. There are chances that the patient does not have any caregiver. At that point, what we do is that we do a police intimation. We inform the police or the ward member who is like within their locality and will be picking up their treatment plan. That is how we usually go about it. Thank you so much for putting up that question. Thank you, Rajeshwari.
So I hope this presentation is clear to everyone. So we have learned many things today. Before moving on to the case presentation, I would like to highlight few points from this today's session, because we used to communicate frequently with the patient and caregivers. And from this today's class, we need to understand that most of while we communicate, we are using non-verbal language mostly. So my request to all of you is our non-verbal expression. Sometimes we will not be aware about that. If you think about something, that will be shown in your on your face. So that will be affecting their emotions. So we will not give any emotional harm to the patient and the caregivers for our through our non-verbal expression. That is one of the important message. You have to keep it in mind and be a good listener. Ask an open-ended question and listen. Try to listen and explore the problem. If you are able to explore the problem, definitely we can able to give some kind of solutions. So that we have to keep it in mind all the times. Okay. So I think we can move on to the case presentation. So Ravina Chatri will be presenting a patient story today.
Yes.
Yes.
ma'am.
Yeah. So can you able to see the slides?
Hello.
Yes, ma'am. But voice is not audible, ma'am. Voice not clear.
Ravina, your voice is breaking. Is there any network?
Yes, ma'am. I'm able to see.
Your sound
I'm
is
sorry,
breaking.
your voice is not clear. I think your voice
Everyone,
breaking.
I'm Ravina Chetri, working as staff nurse in. Am I audible now?
Yes, now it's much
1
better.
second.
Yes.
Yes.
Audible now?
Yes, Ravina.
Yes.
You're
Thank you. I'm working as nurse in Namchi District Hospital in I ward. So today I'll be presenting my case. My patient is a 28 years old male. He came to the hospital with loss of vision and was diagnosed SLE. His diagnosis was loss of vision with SLE. His patient complaint was fever, redness of right eye, loss of vision right eye pain, that's on right eye, and body ache. History of illness. Patient had sudden loss of vision associated with redness and pus from the right eye, then generalized body ache and weakness, fever, inability to move due to body ache and both with loss of vision, and insomnia. On examination, patient was conscious and oriented. His vitals are as shown: temperature 102 degree Fahrenheit, respiration 24, BP 130/90, pulse was 110, and SpO2 was 98%. On numerical score, his pain was 6. And his treatment, where he was admitted in the I ward in government hospital. After doing the routine investigations, his reports were RBS was 102, urea was a normal range, LFT was slightly deranged. His hemoglobin was normal, but his platelet count was slightly on the lower side. His RA factor was negative. His CRP was increased. And after seeing the CRP report, They sent an ANA test and which showed the 1:160 titer, which was weakly positive. Psychosocial aspects. He's a 28-year-old man, married and living with his wife and child. He was sole breadwinner of the family. His wife is a housewife. Now his financial support is from his father, which is making him guilty. He's very anxious about his disease, and he needs his wife's support to do daily chores. On hospital, he was under medication like injection augmentin, injection pantop, injection metrozil, injection diclofenac, and injection tramadol SOS. For the eye, he was given moxiflox eye drop, abpress eye drop, atropine eye drop, lot and ocupal eye ointment. His main concerns were loss of vision, body pain, the new diagnosis that's SLE, and his financial problem. Summary: 28-year-old patient with sudden loss of vision with newly diagnosed SLE. Discussion points. So the first point will be, do we need to provide patient with palliative care? And the second point, how are we going to tell the patient about his illness, that is SLE? How are we going to explain to him? And what can be done for the patient and his family?
Thank you so much, Ravina. I have
Thank
to
you,
say that
ma'am.
you have a very sweet voice, right?
Thank
Okay.
you, ma'am.
So, yes, team. So, does this patient need palliative care? The answers should come from the team, okay? He needs. Exactly. Why? Why do we feel that he needs palliative care? Ravina, can you answer that? No. Why, Rajeshwari, why do we feel that the patient does not need palliative care?
The patient having infection, ma'am. So first you treat the infection. The patient pain score also 6/10 only, not have the more pain. So once first you settle out the infection, after that you control the pain. You next you do for the any surgery for eyes. So the patient is not have any bedridden, he's walkable only, but he's supporting the wife because of the vision problem.
But is SLE a life-limiting disease or not? It is, right? It is a life-limiting disease. And yes, obviously the patient is having support and what is palliative care? I have to like start from there, I think. See, even the patients who are walking with tripods, we do admit them for palliative care, right? It's not just cancer patients. It's people with CVA, it's cancer patient, it's a person with any life-limiting disease will need palliative care. And when we look at the total pain, obviously the pain is 6. I don't know if it's actually 6 because when I look at, we need to have a very like it is chronic can affect different body parts. Yes, definitely. SLE is a very life-limiting disease, and a person who has been independent. When we look at the total pain, the score is less, but when we look at the psychological aspect, there are a lot of scope for exploring more. A 28-year-old young adult with a wife and a very a newborn child. Just imagine the pain that he might be having. I'm not assuming. These are the points that we might need to explore more. And his wife is a housewife, is not working, was completely dependent upon the husband, right? So there is a chance that the pain could be more if at all we have a very vast explorative session. And there is a chance that the person has already accepted the fact that and the pain score is just 6. There is a chance for that also. But obviously the disease condition is a life limiting disease and the patient might need palliative assistance in the future also. What if it starts affecting other body parts? It started with eye. What if it kind of spreads, right? Any other suggestions or any other people who have seen people with SLE or something like that? Any inputs? Nurses, come on. This is like, this has to be your platform where you have to like say, come out and say, speak, right? Any other inputs to this?
Ma'am, living with SLE itself is a challenge. They don't have any control over their own life. In fact, I have a student, she will be coming to the classes for a few days, then she will be getting sick, again will be going back. So we tried actually to tell her that it is not possible for her to continue nursing. So this person who is at such an young age, being the sole breadwinner, he needs support throughout his life, up to which time he is going to be alive, he is going to continuously deal with these problems. The problems may increase only in the future.
Right. Also, see, we had vision till yesterday, and completely I cannot see today. It's a big thing. It's going to be a lot of. I guess we might need a psychologist on board or any other social worker, or who could actually go deep into him, have a very long conversations to know what are other concerns that the person is having. There is like a scope for knowing more. Okay, in that area. How are we going to tell patient about this illness? Any idea? How do you think you might break this information to him? That this is progressive and about his vision, etc. How are you going to communicate this? Okay, we'll just look at the basic communication part. Okay, breaking bad news, as I said, we'll be covering that in the next session, so you will have a very better idea of how to go about breaking the news, breaking the information. But with whatever information, whatever that we learned today. Thank you, Kiran. Thank you so much. Right. So how are you going to communicate? So we'll have a communication with caregivers first, right? We'll sit near, have a very comfortable, build the rapport and have a conversation with the caregivers. We'll get the consent of the caregivers, and then we'll be like breaking the news to the patient. How we are going to break this news? Like, for example, if forget this news, it could be any breaking bad news. Okay, it could be a fact that okay, the disease condition is deteriorating and that the prognosis is bad, and that like, there will be very few days that are left. There are at times we need to break this information. So how we will break this information to patient without being there, as well as you have to actually say the facts as well. We cannot just say everything is going to be right and all. We have to say the facts, but how to put this in words? What are the steps that we have to take up? We have to be very truthful, but slowly release the information. Thank you so much, Rosama. And the whole process we'll be discussing in the next session. Okay, that is happening on Friday. And what can be done for the patient and his family? There are a lot. For example, like I don't know how you people work. I mean, there might be some hospital protocol, etc. Right? See if there is any breadwinner. See if any vocational rehabilitation can be done for the patient or the caregiver. If the child's education or child's medical can be taken care of. See, there are like what we can do for the patient and the family is like a very vast area. But before we do anything, we need to assess whether they are like, may they have any other sources. This might have been covered in psychosocial aspects of palliative care, whether they are getting financial assistance from somewhere else, whether they have like any other support system, whether their family is supporting them, whether their brother siblings supporting them. So we need to look at those areas and then do our part, whether to rehabilitate the patient or the caregiver, to provide with the child's medical or education bills, etc. So the scope is vast, but we need to have a proper assessment for that. Thank you so much, Ravina, for the case. We'll be discussing how to break the news in the next session. Okay, the breaking bad news will be taken up in the next session. Anything else? Any other queries? Thank you, or else we'll wind up.
Ma'am, the breaking the bad news is about whatever I know is spikes, like the communication tool which can be utilized.
Spikes
setting
protocol,
up an interview.
right? Spikes protocol.
Yeah.
Yes.
Yeah, that I think that would be the best way to break the bad news.
Exactly.
So
So
which
we'll
is
be
like
discussing this
very
spike.
difficult.
Right. Thank you so much. We'll be discussing the spike protocol in the next session. The spike protocol, how to break the brag news, everything will be covered in the next session. Thank you so much, Twinkle. So we'll wind up, right? Thank you so much. If at all there is any other queries, please put up in the WhatsApp group. Or if at all there is anything, please let me know in the next session. Thank you. Thank you all. Thank you so for being so interactive. Okay. Thank you so much. Over to
Thank
you.
you, ma'am.
Thank you, Rajika, for the wonderful session. Thank you, everyone, for participating very well. Thank you, Ravina Chetri, for presenting a case presentation. Thank you all for participating. Let's see you in the next session. Thank you. Bye.